Welcome everybody. My name is Arya Shander and I will be addressing Achieving Best Transfusion Practice, transfusion of red blood cells. And our learning objectives for today are that after the completion of this module, the participants should understand the complexity of transfusion, review and be able to evaluate transfusion literature, apply the information to their immediate practice, and be able to rationally incorporate new information on transfusion and blood components into their practice. As we start, basically getting a step backwards to look at where we are with transfusion, you could see that there is a status quo, if you will. The U.S. Department of Health and Human Services in 2006 estimated that there's a total of more than 14 million or close to 15 million units of both red cells as well as white cells transfused in the United States. This has been an increase of 3.3% from 2004. AHRQ in 2007, again, they were able to publish saying that blood transfusion occurred in 1 of 10 of all hospital stays that had a procedure. So again, this was one of the most common invasive procedures that patients underwent. And this was a cumulative growth of 140% from 1997. So despite the fact that there are concerns about transfusions seem to be increasing in numbers significantly and are considered to be one of the top 10. Again, this is, as you could see also, is one of the fastest growing top 5 procedures or invasive procedures in U.S. hospitals. Again, you could see in this slide that blood transfusions, respiratory intubations, mechanical ventilation, as well as hemodialysis and knee replacement are all on the increase, but the one that's increasing at the highest rate has been blood transfusion. This is according to the AHRQ. And we just don't know where, as you could see from these arrows produced, where this slope is going to end. Are we going to see a decrease, an increase, or the same slope over the next few years? Now, what makes things confusing is the current transfusion practices. For years, transfusion practices have been characterized by substantial variations between and within institutions. So both individual physicians as well as institutions have a significant variability in terms of transfusion. Just to quote a few studies, one is Maddox and others, the American Journal of Medical Quality in 2009 showed institutional intraop transfusion rate in coronary artery bypass graft range from 0 to about 86%. These numbers and the variability repeats itself in multiple other studies, some which have been published later than 2009. Turgeon et al. In the Canadian Journal of Anesthesia in 2005 showed different transfusion threshold between different physicians within the same institution and within the different specialties, again suggesting that this is not by any means a science and more behavioral. Lukoski and his colleagues published in early 2010 in Anesthesia and Analgesia, showing again wide variability in current preoperative transfusion practices, especially when guidelines have been constructed for transfusion. And they actually looked at the adherence to transfusion practice guidelines and have demonstrated a very little effect, if you will, of the guidelines in terms of adherence. So the question, of course, that gets raised is why does all this matter? So as you all know, although we constantly say that transfusions are safer than they've ever been, the fact of the matter is that the reality is that transfusions carry significant risk, both infectious as well as non-infectious risk, and are associated with worse patient outcome. Transfusions are also a significant economic burden. They're very costly. Now, they're not necessarily costly in terms of procuring the blood, although there is a significant cost. In the United States, the cost of a unit of blood ranges anywhere from $250 up to $300 a unit. But transfusing that unit of blood ends up being a very complex process. the tests are being done and the processing, if you will, of blood, as well as getting it to the patient in the most accurate way. So the true cost is generally somewhere between 3.5 and 4.5 of what hospital pay to procure blood. The blood supply is also limited. Despite everything that we do, less than 5% of the eligible U.S. population donates blood. And you could see that the difference between the units collected at just over 16 million in comparison to the amount of units that are transfused annually, this is 2006 data, the margin is extremely narrow, and everything that can create an imbalance, if you will, may actually end up with a significant blood shortage. So the marginal supply is likely to worsen due to aging population, again, which in the eyes of many may require more transfusion as they are ending with more complex surgery and higher acuities. Now, when we look at improving our practice, again, the issue, of course, is the training. Despite what's widespread use of transfusions, I mean, every specialty, if you will use transfusion, maybe dermatology not. Blood transfusion remain one of the most difficult medical decisions, but in fact, we don't look at that as a difficult medical decision. We basically go for something called the triggers, or hemoglobin is what triggers the transfusion. And we've also known that the amount of training that clinicians get, both graduate and postgraduate training in transfusion medicine, is extremely limited. Compounding this problem is the lack of data. So that poor training or no training, as well as lack of supportive data and directive data in terms of how we practice, make this, again, a very difficult situation, and you could see why the variability in transfusion medicine. We are clearly moving into a new paradigm that this decision has to be done with considerable thought, and that to transfuse the patient should really be your last resort rather than a default situation, because of these three elements, including risks, costs, as well as the supply, and of course the impact, if you will, or outcome, which has not been as good as we have hoped for in the past. So we'll break these issues down a little bit and go through them. So the first, of course, is safety and efficacy of allogeneic red cell transfusion. So if you introduce a new standard or a new therapeutic agent or a device, you have to perform preclinical as well as clinical studies, they could say 0 to phase 3 studies, to establish both the safety as well as the efficacy in the target population for the intended indication. So keep in mind that there's a very rigorous process establishing both safety as well as efficacy, as well as the population that will benefit from this particular procedure. When we turn our attention to blood transfusion, you could see that it's the test of time. Blood transfusion have been around for more than a century and essentially have been grandfathered into our practice. There have been no pivotal randomized controlled trials, and the likelihood of those being done with a control group not receiving any transfusion versus the experimental receiving transfusion will never be performed. Some feel because of ethical reasons, others feel because nobody wants to be in a control group. In addition to that, if we ask for the witness population to be the control group, we can't randomize them. So you could see that, again, this is a serious issue. So the benefits over the years have largely been assumed. If blood saves lives of trauma patients who used to bleed to death, actually it's also the obstetrical patients were the first to be treated, the hemorrhaging obstetrical patients were the first to be treated this way. It must be good for many others, meaning that we extrapolate that those patients who are hemorrhaging benefit from that blood, although in the early days when studies were done, it seemed only 50% survived, so it's not a large number. but we extrapolate that other patients will benefit. But in fact, what's happened over the years that for red cell transfusions, the default is not the hemorrhage, but the low hemoglobin or anemia, which has multiple ways of being treated. The benefit of allogeneic transfusion clearly is being examined now, and we see that there are now a significant number of observational studies, very large ones, and clearly if you put them all together, have a signal that suggests otherwise in terms of benefit, that actually they convey risk or may actually have negative outcomes such as increased morbidity and also increased mortality. The other thing that is sort of ties to the issue of safety and efficacy, of course, is how efficacious this red cell that has been stored in terms of oxygen delivery and oxygen utilization, which is really the reason or the major reason for transfusion of red cells for those patients who are anemic. So blood as a volume expander, again, is only helpful, if you will, in massive bleeding and shock, but keep in mind that that is not the only panacea, that this requires somebody to stop the bleeding. So stopping the bleeding, blood becomes then part of the armamentarium of resuscitation. As you could see, we can have non-cellular products do just as well, if not better, in terms of maintaining resuscitation of patients. And even though we do this, large amounts of red cells may end up with what's called TACO, which is transfusion-associated circulatory overload. When we get down to the microscopic range, if you will, of a blood transfusion, we need to look at the impact of red cells that have been stored on the microcirculation and the endothelium. And this is where blood may actually be a viscous entity that helps maintain not only flow, but may actually improve oxygenation, because it's the viscosity to do that. But keep in mind, we have many other ways of improving viscosity. So viscosity is important in terms of keeping blood flow in the capillaries, as well as slowing down the small amount of red cells in someone who's significantly anemic to allow for oxygen delivery and oxygen utilization. So in patients who have low to moderate hemodilution in the microcirculation, viscosity helps in maintaining oxygenation, but again, blood doesn't seem, and that is bank blood, doesn't seem to have an important role there. So the other problem, of course, that stored blood may not per se increase delivery because this blood is devoid of 2,3-DPG, and oxygen, although gets loaded onto the hemoglobin molecules, it does not get unloaded effectively in the periphery where it actually functions. So take a step back and take a look at the physiology of oxygen transport. And unfortunately, keep in mind that these equations really look at hemoglobin delivery and red cell delivery, but don't have much to do in terms of oxygen unloading at the periphery. So the global oxygen delivery, as signed DO2, is a function of cardiac output times the arterial oxygen content, which is CaO2. Arterial oxygen content is made of the saturation of oxygen with a constant of 1.34, the amount of oxygen that hemoglobin can carry, times the grams of hemoglobin available within the circulation. So that gives you the idea of how much hemoglobin bound oxygen is being delivered, or the content of that. Now, plasma is another vehicle for transport of oxygen, but the amount of oxygen dissolved in plasma, as you could see, is a relationship of the arterial oxygen, which comes from the alveolar oxygen. And that is a very, very small fraction of the total carrying capacity of oxygen, unless the hemoglobin amount, as you could see in red, the hemoglobin amount is reduced significantly. And now this plasma contribution is much more significant than it was when you have normal hemoglobin available. This, as you know, is the famous oxygen dissociation curve. We're looking at oxygen content in red cells as well as in plasma. And you can see that plasma has a role, but it's very small. But if you have very low hemoglobin, as I mentioned before, now this contribution becomes much more efficacious in terms of the body seeing the oxygen molecules being delivered. And again, here depicts the carrying capacity of oxygen as hemoglobin concentration are reduced. So if you move from a hemoglobin of 12 down to hemoglobin of 0, you could see how the contribution of oxygen from the hemoglobin is reduced. And again, what you're now seeing, the increase in the amount of oxygen in the plasma may now be a much more of a significant contributor, especially if you end up in a hyperbaric situation. But there are some caveats with hyperbaric situations that need to be accounted for, one of which is reduced perfusion through vasoconstriction. Now, ultimately, delivery of oxygen is good, but what's better for the tissues is the consumption. And global oxygen consumption, assigned as VO2, is the amount of oxygen consumed by the whole body per minute. And that leads us to something called the extraction ratio, the O2-ER, which is oxygen utilized over the oxygen delivery. And again, you can see there's always a margin between 20 and 30%. There's no ischemia, actually, for the organism if oxygen utilization is always less than oxygen delivery. But you need to have that margin. As margin closes between VO2 and DO2, you become what's called supply dependent, and you could see that that can result in ischemia. And we know from data in humans, and this was actually one patient who was invasively monitored after a significant gastrointestinal bleed, and this was done in the Netherlands, that DO2 becomes an issue when you go below the 200 level. At that point, what happens, you become what's called supply dependent. You cannot meet the needs of your oxygen utilization, which is VO2. So you could see in this slide that there are three situations, but if we take the green, which is situation number one, as your DO2 is lowered, meaning that the delivery, which is usually governed by hemoglobin, is reduced, you could see again that you don't reach a critical point until you're somewhere around 200 to 300 mils per minute of DO2. And then the supply it gets reduced, but now it's affecting, if you will, VO2, which is measured on the y-axis. So as you could see in majority of patients, even with severe anemia, VO2 is unaffected for quite a while as DO2 is reduced. So there's an independence, if you will, until you reach that critical point. Now, supply dependency, as I mentioned to you, is shown in case 3, where you're dropping below what you can actually safely utilize, and the patient will become ischemic. So when you reach the O2 critical or O2 crit, as depicted in the slide, you can do a couple of things. You can either increase DO2 or possibly reduce VO2 or do both. So the two common ways to manipulate DO2 in the clinic, one of them, of course, is to increase your oxygen concentration. But the one that's been a default for years has been transfusion of red cells that have come from the blood bank. So the premise, if you will, of transfusion is, number one, you're reaching a low DO2. That's defined here as the patient being anemic. Anemia, again, is thought to increase the risk of ischemia, which it may. And then the response by the clinicians is to transfuse the patient. Transfusion results in increased hemoglobin, which then increased DO2, which then is thought to increase VO2 and therefore prevent or treat ischemia if it happens. But let's examine this, because I think that we know differently today with the data that we have. So this is, again, a large study looking at multiple different studies in a systematic way. You can see the author on the left, the population of patients as depicted, as well as the number of patients in each one of the studies. Not a large number, but in total, clearly something to contend with. And then looking at the number of units transfused in each of these studies per patient and whether that increased hemoglobin and whether it actually improved the delivery of oxygen. You could see that 2 out of these 9 do not have an increase in DO2. However, what's impressive is that VO2, meaning the difference between the two or measure of oxygen utilization in the tissue, actually was not common because only 3 of the 9 actually had any improvement, and it wasn't always great of VO2. The rest had no improvement of VO2. And you could see that just shy of half, had no improvement in lactate in terms of reducing it, and the others, it was questionable whether there was any, again, impact on lactate production. And again, you could see this is more of the same, with the same results, if you will, in terms of the VO2 relationship to DO2. And again, you could see that DO2 is not universally increased in these patients who have been transfused. But VO2, which is tissue oxygen utilization, as we already made the point, does not occur with transfusion, which is what is expected, if you will, from any of us who are giving blood. So when you look at a summary of this, is that in all of the studies, hemoglobin increased, and we know that will happen. In 80% of the studies, DO2 increased, so it's not 100%. Only 16% of the studies, there was a concomitant increase in tissue oxygen utilization, which is the ultimate goal of transfusion. But again, in none of the studies, ischemia as measured by lactate improved. So again, what's missing here is not the immediate measurements, if you will, but the impact on patient outcome. And we've had significant number of observational studies, which are always argued in terms of their validity, but the fact of the matter is that literature is burgeoning and growing on a daily basis. In this particular slide, we're looking again at multiple studies performed. These are all observational studies, but you could see the numbers are much larger than the previous studies that we looked at. And these studies, we are looking at the different population of patients. You can see the N, and it's significant, clearly more than 70,000 to make a quick statement. And then looking at the impact of blood transfusion in terms of morbidity and mortality. And you could see that in all of these, there was a mortality signal, if you will, in these patients, as well as length of stay. But also there have been others looking at, some of these do already, but others that are looking at morbidity. And again, in this slide, we're just adding more and more patients. So you could see the numbers are clearly much greater than in the initial DO2, VO2 studies. So the impact, if you will, or the negative impact, may not be a causality issue, but clearly is related to transfusion. And if we can control this, the question would be, of course, is there would be nothing wrong because we can hopefully improve on patient outcome. But if not, we're not doing any more harm, if you will, by withholding or reducing the amount of transfusions or following, again, guidelines, which would end up with a lot less transfusion that we have currently. So studying comparing blood transfusion with no transfusion are unfortunately uncontrolled and observational. So the issue, as I mentioned already, is that controversy is that transfusion causing worse outcome versus transfusion making sicker patients. So the issue is whether transfusions cause worse outcome in these patients or the transfusions are a marker for sicker patients, meaning that the sicker patients tend to be transfused more. And this is the old argument with the chicken and the egg. But as I mentioned already, there's no real downside to one or the other of this component of the question, because whether they cause this negative outcome or mark patients that will have a worse outcome, controlling transfusions may actually have an improvement, both in terms of resource utilization as well as maybe even improving the mortality and morbidity we've seen. But again, statistical methods to adjust the confounders for these problems. Transfusion always, or I would say more than usual, remains as an independent factor associated with worse outcome in these patients. Now, where are we with randomized controlled trials? So randomized controlled trials have been done since the 90s, and they're basically looking at two arms, one of which is a restrictive transfusion trigger, meaning a hemoglobin at which transfusion will occur, versus a liberal transfusion at which the old adage of 10 grams per deciliter is being used as, if you will, a standard for the transfusion. So in 1999, New England Journal of Medicine, this was probably the pivotal study looking at the transfusion in critical care. This is a Canadian-initiated trial, and you could see 838 patients. There was overall mortality was the same with the liberal versus restrictive. So the ad hoc analysis of this study looked at mortality rates, and what was astounding was that, and this is a typo on the slide, is the mortality in the restrictive patients with, again, lower Apache scores, meaning the less sick patients, was worse than in patients who were young and those who were 55 years of age. These are the patients we expect to go home rather than to have an increased mortality, which is associated with, again, the transfusion. Another analysis of this cohort was published in 2001, critically ill patients with cardiovascular disease. This was a smaller study, and overall rates of mortality was similar. However, despite the findings, the recommendation is that, again, the patients who received who have underlying coronary disease should be transfused at a higher hemoglobin, despite the fact that, as I mentioned already, there was no evidence for that. But the restrictive group in this trial had less multi-organ failure than the liberal group. And then, again, in CHEST of 2001, critical patients undergoing mechanical ventilation were found no difference in duration of requiring respiratory support. So respiratory support, ventilatory support does not get alleviated with transfusion, which is still some kind of a dogma that many clinicians adhere to. Other studies, again, listed over here, that all following the same group of patients, but different analysis. This one was 2004 by Neil McIntyre, looking at critically ill trauma patients. And again, similar mortality between the restrictive versus liberal. ICU and hospital length stay and multiple organ failure was higher in a transfused versus non-transfused. Grover and his colleagues published in Voxang in 2006, elective hip and knee replacement in 260 patients. There was similar incidence of silent myocardial ischemia and length of stay, again, not showing any incremental benefit of transfusion to a higher hemoglobin level. Again, another McIntyre study looking at critical trauma patients with moderate to severe head injury. This is a smaller study, no difference in mortality, length of stay, and multiple organ failure. But I have to tell you that there are studies coming out today that are poorly conducted but have changed, if you will, the neurosurgical environment to have a lower threshold, if you will, for transfusion. And last on this slide is Foss, looking at elderly patients with hip fracture, similar postoperative rehabilitation scores and length of stay. Again, if you will, arguing the fact that many rehab centers require high hemoglobin, thinking that these patients will do better postoperatively with rehabilitation if their anemia is taken care of with transfusion, rather than other modalities which may be not as risky as an allogeneic transfusion. So the results, if you will, are based on average population. But as you all know, we have to contend with one patient at a time. And when we have to do that, the best decision is sometimes not reflected by guideline, but is reflected by our experience, by the patient's desires, if you will, as well as the patient condition and age. So we need to identify the patient who is likely to benefit from a transfusion. If we have not been able to do that, other than those patients who are exsanguinating. So can we measure any way, non-invasively, tissue ischemia, and will transfusion improve that? That's still debated. And improve patient outcome, meaning can we show improvement in patient's health and survival, and that we have not been able to demonstrate it with transfusion. So transfusion criteria other than reflex transfusion based on arbitrary hemoglobin and hematocrit thresholds alone is what we're contending with right now in medicine. But we need to have better transfusion practices, and probably what we need most is non-transfusion practice, where transfusion becomes the last resort for those patients for whom blood is an option, rather than the first resort to treat anemia. So we are going to be looking at guidelines, and there are there are four major guidelines as grouping. First is the College of American Physicians. Again, the general message in that guideline is practice parameters for the use of red cell transfusion, the development by the red blood cell administration practice guidelines. This was a task force of the College of American Pathologists, and it was published in 1998. So we know that these are not up to date, but still the same message, if you will, resonates amongst all of these. The next one is the American Society of Anesthesiology, looking at perioperative transfusion, and their practice guidelines for perioperative blood transfusion, as well as adjuvant therapy, was published in 2006. This was second edition, or if you will, improved guidelines, updated guidelines in 2006. The Society for Thoracic Surgery had, again, this is a cardiac surgery. They looked at perioperative blood transfusion and blood conservation in cardiac surgery. So their guidelines were a lot broader than just transfusion, because they were looking also at blood conservation. And this was updated, but the initial one was published in 2007. The key other guidelines include the Society of Critical Care Medicine, and this was specifically directed towards the critically ill patients, and this was only on red cell transfusion in adult trauma and critical care, and this was published in 2009. A couple of statements over there, again, are repeated and are similar to the other guidelines that I mentioned, and some of the statements may be slightly overreaching. SIMT, looking at the pre-op transfusion, these are recommendations for the transfusion management of patients in the perioperative period, and this was, again, published in Blood Transfusion in 2011. Not very dissimilar to what the others have in their content. And ABB just had theirs published early this year. This is red cell transfusion guidelines for patients who are hemodynamically stable. Red cell transfusion, a clinical practice guideline from the ABB, was published in the Annals of Internal Medicine, as I mentioned earlier this year. So what are the target setting? And let's break these down. So this is the CAP guidelines. Again, they looked at acute hemorrhage and pre-op, chronic, such as hypoproliferative, meaning bone marrow failure and chronic blood loss, which is usually GI. And the hemolytic anemias, as well as transfusion-dependent patients, was not discussed in these guidelines. So what's salient is for acute anemia, the main factor to consider is the hemoglobin before blood loss, the extent of the blood loss, and then the presence of conditions that may affect anemia tolerance. And those are not specified. Hemoglobin-based transfusion recommendations are that patients who have hemoglobin less than 6 grams per deciliter, and you could see again, almost always indicated to transfuse. It doesn't require they be transfused. So again, it becomes a clinical decision based on the individual patient. A hemoglobin greater than 10 grams per deciliter states here that it's rarely indicated to transfuse, and those rare times are becoming even more rare than now that we understand some of the anemia. So it leaves you with a gray zone of 6 to 10 grams per deciliter, which now depends on the extent of blood loss, underlying cardiac disease, which again is one of the results of that publication I mentioned from Polybier, where they looked at the data of the randomized controlled trial. Although they had no data on this, this keeps repeating itself in the guideline that patients with cardiac disease have a lower threshold for transfusion. In fact, the only data that's out there suggests that these patients do just as badly or just as poorly as expected from other patients who get transfused unnecessarily. And, looking at the overall clinical status. So keep in mind, these are very broad in general. Again, you're looking at the extent of blood loss. Previously healthy patients, usually no need to transfuse. And that's a significant advance, if you will, with 30 to 40% of total blood volume loss. Again, the recommendation is to use acellular fluid to replenish them. Patients who have comorbidity may need to be transfused at that point, but again, no data support that depending on the hemoglobin level and the nature of the disease. And again, it says nearly all patients may need blood at a loss level above 40% or close to half of their blood volume, which may or may be correct depending on the patient's starting hemoglobin. So the question, of course, is how to make the final decision and how do you monitor response of the transfusion. Well, ideally, you want to look at indicators of peripheral tissue oxygenation. Unfortunately, the only way to do that is invasively with experimental equipment. So again, looking at vital signs, including heart rate, blood pressure, hemoglobin, and whether bleeding is active, controlled, or uncontrolled, will sway you in terms of the decision to transfuse or not to transfuse. In the surgical settings, as you can see from this slide, again, the recommendation is to refrain from prophylactic transfusion, meaning not to just transfuse based on the hemoglobin as a trigger. You need to consider clinical signs and symptoms and prior medical history. Again, vital signs alone may be inadequate in anesthetized patients because, again, the effect of anesthetic agents as well as the question of possible silent ischemia may plague this population. So the first step is to correct the volume. We all know that perfusion is important, so you can have normal amounts of hemoglobin, but if there's no perfusion to the organ, you're not going to get oxygen delivery. If we use the same principle in patients who have low hemoglobin, then you want to maintain perfusion, and you could do both. You could do it with both crystalloid as well as colloid. Again, keep in mind that a unit of red cells will raise a patient's hemoglobin by 1 gram. This is an adult 70-kilogram individual. The variability is somewhat there, but in general, it's a good rule of thumb. So 1 unit may be enough to raise somebody from a hemoglobin of 5 to a hemoglobin of 6, but yet many people still order 2 units of blood. Again, if there is oxygen deficit present in acute hemorrhage, then the blood is recommended to be given quickly. And again, watching for all the side effects which are associated with rapid infusion of blood, including excessive potassium with deadly hyperkalemia, may be a cause of those patients' demise rather than the underlying medical condition. As far as chronic anemia goes, in this slide, patients already have rebalanced their circulating volume. So again, there are treatments that can be applied to these patients, none of which require transfusion. And these treatments should be targeted to the cause of or the underlying cause of the anemia, and you can see that spelled very nicely in this slide. For each patient, a target hemoglobin level below which symptoms and functional impairment are exhibited should determine whether transfusion is necessary or not. But in fact, each patient may have a different responds to the level of anemia, so that each patient needs to be examined individually and not just used on a one-size-fits-all. Now, this brings us to the American Society of Anesthesiology guidelines. And again, this is the perioperative patients, and pre-op evaluation is necessary to get the best information on the patient, including medical history, family history, and lab results. You need to identify the risk factors, both ischemia as well as coagulation issues. Those can always be addressed prior to the patient going to surgery, especially if it's elective surgery. And again, looking at red cell mass optimization, meaning improving hemoglobin, can be done pharmacologically, especially knowing the underlying cause of the anemia, whether it's nutritional or not. And of course, adjusting anticoagulants will help in terms of stabilizing coagulopathy in these patients. Monitoring blood loss, as you can see in this slide, and making sure that we have good tracking of it, monitoring hemoglobin, as well as some of these perfusion monitors that are now available for both non-invasive as partially invasive monitors, will help in terms of assessing the patient's circulating volume, which is very, very important for perfusion. As far as indications for transfusion, as you can see that this is very similar to CAP, stating that less than 6 grams per deciliter patients may be indicated for transfusion, and it be rarely indicated for patients with hemoglobin greater than 10, and the same in terms of the gray zone between 6 and 10 as described on the slide. The SDS guidelines, as I mentioned, are slightly different. They're looking at a very specific population, which is cardiac surgery. And again, they are recommending the same in terms of the initial, that patients with less than 6, it would be reasonable to transfuse. Again, reasonable in most postoperative patients, a hemoglobin is less than 7, but there also the caveat here is that there's no data to support that. In fact, they're better off because they've had their cardiac disease repaired already, so it makes no sense. Not unreasonable in certain patients with critical non-cardiac end organ ischemia, although again, keep in mind there's no evidence to support that, and transfusions are unlikely to improve oxygen transport and not recommended if hemoglobin is greater than 10 grams per deciliter. Again, for coronary bypass grafting, it's reasonable to have patients remain with a hemoglobin of equal or less than 6. In patients with hemoglobin greater than 6 grams per deciliter, they would consider, again, transfusion in patients who are elderly with severe illnesses, meaning comorbidity, cardiac dysfunction, risk of critical end organ ischemia. Again, if there's massive bleeding or hemorrhage, that changes the clinical setting. And the parameters, again, are used here, but there's no data to support that. Now, patients who have a risk of decreased cerebral oxygen delivery, according to the SDS guidelines, may be a population that would be reasonable to transfuse them. But again, keep in mind that there is no data, especially with the last sentence, which says that it's not unreasonable to keep a hemoglobin greater or equal to 7 grams in patient with risk of critical end organ ischemia and injury, mostly pertaining not necessarily all to the myocardium, some to the myocardium, but mostly for the central nervous system. For the Society of Critical Care Medicine guidelines, again, here we targeted the critically ill patients. Red cell transfusions in general are indicated for patients with evidence of hemorrhagic shock. And as I mentioned, that is part of the armamentarium of resuscitating the patient. It is not the whole story. You need to have somebody stop the bleeding. Red cell transfusions may be indicated for patients with evidence of acute hemorrhage and hemodynamic instability or inadequate oxygen delivery, which here talks about hemorrhagic shock. They recommend that a restrictive strategy, transfusion when hemoglobin is only less than 7 grams per deciliter, is as effective as liberal transfusion. Again, we've known that from the previous studies done in critically ill patients. And again, you could see the caveat or that they represent here, which has no data, is except possibly in patients with acute myocardial ischemia. And to appease those, I guess, who objected, is the word except possibly. Use of hemoglobin level alone as a trigger for transfusion should be avoided. Decisions should be based upon patient's intravascular volume status, evidence of shock, duration, extent of anemia, as well as the cardiopulmonary and physiologic parameters. So again, to continue their description, you could see here that RBC transfusion in general, in the absence of acute hemorrhage, there should be transfusion done only of a single unit of red cell and not in terms of multiple units of red cell. So the consideration is for hemoglobins less than 7 grams per deciliter, those patients requiring mechanical ventilation, but as we already mentioned in previous slides, there's no data to support that. Consider also a hemoglobin less than 7 in patients who are resuscitated from trauma. Consider transfusion again with a hemoglobin less than 7 in patients with stable cardiac disease. There's no data supporting that. And again, RBC transfusion should not be considered as an absolute method to improve VO2, since all the data in critical care does not demonstrate that. And transfusion should not be considered as an absolute method to improve VO2, as we demonstrated already in previous slides. That has not been shown to increase VO2. That is, red cell transfusion have not been shown to increase VO2. Now, patients with coronary disease, again, you're seeing this as a number as well as a recommendation, but repeatedly, you know that the data is not there to support the statement. So it's been handed, if you will, from one slide to the next and from one individual to the next, and we do need data. Now, we do see quite a significant number of patients who have sepsis, and again, RBC transfusion in septic patients. Because of the risk of infection, each case must be assessed individually, since optimal transfusion level or trigger in sepsis patient is not known, and we don't know actually if these patients improve with it. Transfusion of red cells in patients with acute lung injury or adult respiratory distress syndrome, all efforts should be made to avoid transfusion in this population because of the acute lung injury associated with red cells who have been stored and transfused. Now, here they recommend RBC not be used to wean patients off ventilator, and I think that's a very good recommendation. Patients who have neurologic disease still is a dilemma. There's no benefit of liberal transfusion with hemoglobin less than 10, greater than 10, I'm sorry, with patients with moderate severe traumatic brain injury. Patients with subarachnoid hemorrhage must be assessed individually, since optimal transfusion triggers are not known, and that is also true today. Now, here you're looking at the perioperative period of these patients and looking at these guidelines in terms of the amount of hemoglobin. Again, they're trying to address, if you will, the clinical conditions and any sign of reduced oxygen delivery as the reason for patients to receive transfusion. They're recommending point-of-care hemoglobin measurements, and in acute hemorrhage, consider the amount of blood loss and clinical conditions. And as you look at this here, they're looking at percent of blood loss in these sub-bullets and have translated these into loss of actually circulating volume, which seems to or appears to be in a 70-kilogram individual. So these are large volumes, if you will, and of whole blood that's, again, considered in terms of replenishment for red cell transfusion. In acute anemia, you could see the same numbers coming up again of less than 6 grams per deciliter. You could see that transfusion of red cells is almost always necessary. But that may not be the case depending on one patient, each patient we examine. Here you see when hemoglobin is between 6 and 8, RBCs may not be necessary unless there is other risk factors, annulus cardiac disease, or the presence of signs of tissue hypoxia, such as tachycardia, hypertension, ECG signs of ischemia, as well as lactate acidosis. Those are, again, the caveats where RBC transfusions should occur between 6 and 8. And they've divided now to 3, if you will, so now the next level is 8 to 10. And here, tissue hypoxia would be a driver for transfusion, and they do not recommend, like all the others, that hemoglobin of 10 be your, if you will, borderline. And here again, they're showing that the hemoglobin of greater than 10 grams per deciliter is not indication to transfusion. And just like early on, RBCs should not be used for volume replenishment. There's plenty of non-cellular fluid that can be used for that. Now this brings us to the late guidelines, which have been published by AABB, and the target setting here is hospitalized hemodynamic stable patients, again, not hemorrhaging patients. And starts off by recommending a restrictive transfusion approach to patients or practice. And that transfusion decisions should be based on both hemoglobin level as well as symptoms. And in the intensive care unit, you could see it's very unclear, but patients who have a hemoglobin of less than 7 should be transfused based only on data that we have because no one checked below 7. So in the TRIC trials, that's what they had is 7. Nobody actually looked at hemoglobin of 6. So the recommendation, although there, should be executed as a patient by patient. Here also the recommendation is a hemoglobin less than 8 grams per deciliter in patients undergoing surgery. And we can argue about that. And signs of inadequate oxygen delivery, again, should be a consideration for transfusion. You could see how that's broken down. In hospitalized patients who are hemodynamically stable with pre-existing cardiac comorbidity, restricted transfusion strategies, which is very new, and I think actually make these guidelines useful as opposed to previous guidelines where the presence of cardiovascular comorbidity was an indication itself for transfusion. But here you could see with the hemoglobin drop below 8 grams or was less than that in the presence of symptoms, again, under those circumstances, the ABB guidelines recommend transfusion. With patients with acute coronary syndrome, recommendations could not be made because of the limited evidence available. So again, you're left to determine that individually. And more research, of course, is needed. And the research, unfortunately, is directed towards hemoglobin level, meaning restrictive versus liberal, rather than no transfusion, as we mentioned earlier in our discussion. So there are common themes. Hemoglobin alone is usually not very informative parameter to use as basis for transfusion decision. So again, between 6 and 10 is the gray zone. Less than 6, high probability of transfusion. Greater than 10, a very, very low probability for transfusion. The other factors to consider, of course, is the age, comorbidities, although again, data is not available in terms of patient outcome. Does a patient outcome improve with that? And we don't know that. So other potential important factors to consider include patient factors, but again, keep in mind there's no data supporting transfusion because of advanced age or multiple comorbidities. The procedure, meaning the extent of rate of blood loss, that's always been taken as a doing business as usual. In fact, we're now looking at containing and reducing the extent of blood loss in surgical patients. And the evidence of ischemia in many of these cases is very difficult to assess non-invasively. But again, these are things that suggest that transfusion be more of a clinical decision rather than a mathematical decision based on hemoglobin. Again, high-quality evidence, and that's a euphemism for randomized controlled trial, is not available, is very limited. But in fact, we have many other studies out there, so keep in mind that those do have to be taken into consideration. Again, the ultimate goal of transfusion is not achieving or maintaining an arbitrary hemoglobin level, but avoiding ischemia and improving outcomes. Both of those, again, need to be demonstrated in in a very clear fashion, and unfortunately that's not the case. And again, another call here is that single unit transfusion, rather, unless the patient, of course, is hemorrhaging, rather than multiple unit transfusion be the norm, rather than the 2-unit transfusion, which have been recommended for years. So putting this into a table, you could see again, I'm not going to go through that in detail, but you could see where some of these the overlap considerably in terms of their recommendation. So whether you subscribe to any one of these organizations, you could see that there is clearly significant overlap in their recommendation, and they all lean towards a restrictive transfusion threshold, as well as trying to make an assessment based upon the patient rather than the group of patients. Physiologic triggers, just to give you a assistance, if you will, in terms of how to address those. None of these parameters have been shown to have significant improvement with transfusion, but are considered in many ways as an indirect measure of ischemia or acute comorbidity. And here we're looking at mean arterial pressure, heart rate, new ST segments associated with depression, and you have 2 of those. Transesophageal and thoracic echocardiography with wall motion abnormalities. And then you've got pulmonary venous O2, extraction rate of oxygen, as well as a systemic oxygen concentration, and again, a measure, if you will, of VO2. But it's always difficult to assess these because the condition that these patients are under, surgery and anesthesia may all be altered and may need to be taken actually with consideration of, number one, what the hemoglobin is, the rate of blood loss, and whether there are other modalities that can be used to improve the patient's physiology. So there have been some other recommendations over the years. This one came from Canada, looking at the rate of drop of hemoglobin, which is suspected, at least in this particular trial, that if you drop hemoglobin very rapidly, that the outcome may be worse in terms of dropping it over a period of time, where there's significant amount of time for compensation in terms of the drop of hemoglobin. But we don't know that transfusion can reverse this. So this is just the measure of the change in hemoglobin without proof that a transfusion of, again, stored hemoglobin will do that. So again, this depicts the same issue as I just mentioned, looking at the delta hemoglobin versus just the absolute hemoglobin drop. Looking at the percent change from baseline, looking at the age of blood, looking whether the blood has been leukoreduced, which is very, very common today. But again, keep in mind all these things can be helpful. But what is clearly the change in paradigm today is stepping aside from transfusion and looking at other ways of preventing the patient from getting into the point of requiring a transfusion. And that's called, again, patient blood management. So the way to avoid that is to make sure that all of the signs that we have that lead for patients to be transfused, such as preoperative anemia that's not managed well, if that's addressed, we can either reduce or eliminate the exposure of patient to allogeneic transfusion. So as we're wrapping up, these are some of the best practices in transfusion. You could look at our example from EHMC, looking at our transfusion order set. So we need to know whether the patient is bleeding or not. If the patient is bleeding, do we have any evidence of active ischemia? And do we also have the hemoglobin? Again, if the anemia is chronic, is it being tolerated, and can we use other modalities to treat the patient? Is the patient symptomatic, and if they are, can the symptoms be corrected with, again, other modalities rather than transfusion? And if the patient is undergoing treatment, such as chemotherapy, for example, as a significant cause of anemia. Is there a way for us to preemptively increase the hemoglobin such that it doesn't reach the nadir that requires a transfusion under those circumstances? The other thing that we can think of or recommend is a transfusion decision checklist. That's another way of looking at the same process that we go with our order sets. So before considering transfusion of red cells, have you optimized the patient's hemodynamics? Have you optimized oxygenation, both dissolved as well as hemoglobin oxygen? Was the patient given a trial of iron? If they have nutritional anemia, you could see the replenishment of vitamins and iron. And consider, if the patient has inflammatory anemia, the use of, again, erythroid-stimulating agents to overcome the reduction of EPO production by patients who have inflammatory disease. Again, adding to this decision tree has every attempt made to stop the bleeding. Many times transfusions are considered before the hole is plugged, if you will, and under those circumstances, loading it with blood and with other fluids may end up with a coagulopathy. One of the challenges for all hospitalized patients is their production of anemia from phlebotomy. And one of the things that we ask people to do is rethink whether they need the test they're ordering. Ordering tests on a daily basis just to have a result on the chart is clearly harmful for patients, because there's been numerous publications demonstrating that that is one of the major causes, as well as one of the major aggravators of hospitalized patients' anemia. And again, looking at the delta, if you will, of hemoglobin as a checklist item, and looking at any evidence of ischemia, also a consideration in this checklist. If the patient does end up requiring a transfusion, these are some of the checklist steps that we must take. First, if it's a capacitated adult patient or capacitated patient, informed consent is essential, meaning explaining all of the risks, all of the benefits, and all the alternatives. Again, avoiding pre-medications in the absence of history of recurrent transfusion reactions. But in the presence of transfusion reactions, we recommend consulting an expert under those circumstances. Single unit transfusions are now the norm of the recommendation. And again, using the lowest possible dose to achieve whatever it is your target endpoint is also recommended. And monitoring clinical response is essential to know that you've actually improved on the health of a patient with transfusion rather than made them worse. So this brings us to, again, looking at the three pillars, if you will, of patient blood management. And they are basically divided, if you will, in a perioperative period into the preoperative period, where we want to look at the patient's hemoglobin level and optimize that. By going into surgery with a normal or even high hemoglobin level, the likelihood, even if you bleed significantly, of you reaching a nadir hemoglobin, which is less than 6, where transfusion are more likely, will not happen. Collecting blood during surgery and returning it to the patient if it's sterile is very easy to do and should be done for all patients undergoing surgery where significant blood loss is occurring. And lastly is to make sure that we could treat these patients with either iron or other vitamins if they have nutritional or iron deficiency postoperatively. And that brings us to the end. Thank you very much.